What is up, everybody? Welcome back. It's Jtrain again, back on the podcasting scene. I know that I did a podcast a little recently with my friend Will, and it reminded me just how much I enjoy podcasting, and it just reminded me how many awesome friends I have with awesome stories that I think would be great to kind of talk about with podcasting and everything. And what better time than now with the COVID-19 thing going on than to connect with people? Especially those that you no longer see on a regular basis, and that is one person that I have on the line currently right now. One of my favorite ex-coworkers, Julie. Julie, how are you doing today?
It's a good day.
It's a good day.
Good day.
Are you ready for the weekend? We have a 3-day weekend coming up.
Some people do. I will be working Sunday through Tuesday.
Oh, so I guess that's a fantastic segue into maybe discussing what it is that you do for a living. I mean, you work in health right now, and I know that you have kind of like a nursing background, but I don't know if that's what you're actually doing right now.
Sure. So I I'm an emergency nurse in infectious disease, which is how I know you.
Mm-hmm.
And I was back in the emergency room at a level 1 trauma center. So that means we get all the gunshot wounds and all the fun, cool stuff. But I was diagnosed with breast cancer in March, so I was moved over to poison control. So now I'm the friendly voice on the phone when children eat too much or people overdose or you eat a weird berry when you're hiking. I'm the one that tells you what to do.
So they moved you over to poison control because you had breast cancer for like a specific reason, or because?
Yes.
Okay.
Yes. So when you have breast cancer or you're on chemotherapy, you don't really have an immune system. And so it would not be safe for me to be coming in contact with patients who might have COVID or might have any other kind of infectious disease process in the emergency room. So for my safety, my manager was really gracious and moved me over. So I work in an office now.
Oh, that's really great. And I do want to get into the breast cancer thing, before the end of this podcast and everything. But what I really want to talk about, starting is, the hot topic for who knows how much longer is going to be COVID-19. And just to let, I guess, kind of listeners know, I for those of you who don't know, I started off like my career in epidemiology, infectious disease and stuff like that. So I'm kind of plugged into, the severity of this, having experience being in epidemiology. I know like kind of the resources it would take to handle something like this. I never thought that I'd actually see like a modern day, pandemic that touches every aspect of our lives, so much. And I guess you'd be like the perfect person to ask. I mean, there's so many things we can get into here. Like I'd like to know how Virginia is dealing with this, how you think Virginia is dealing with this, kind of what it's like on the ground. So I imagine that emergency health is hectic to begin with on a regular basis, but now it must be overwhelming. And I think that you did maybe have some sort of encounter, at least recently, with not getting COVID, but like dealing with a hospital setting, or maybe still do a hospital setting with COVID. So if you could maybe, because I think the general population understands that this is like a big deal, but it's just one of those things where it's kind of like how I think people view like starvation, like in a developed country like the United States or something, dealing with like actual poverty and stuff. It's kind of, I guess, hard to fathom unless you've actually like witnessed it, seen it, experienced it. So what do you think that people know just how, I guess, insane this is, or do you even think that it is over the top insane, or what are your kind of, I guess, initial thoughts on this in the health sector dealing with it? Your
One thing
experience.
I always like to remind people is this is a novel virus. So it's the first time we have seen this type of virus, this very specific strain of virus, jump from an animal source, and we know it's an animal source, to humans. So we can kind of plan based on what we understand about a similar type of coronavirus, like SARS or MERS, what that does and kind of how the virus operates. But because we've never seen it before, everything that we're doing whether it's working for vaccines or in the hospital setting, is based on an educated guess. Science is very conservative in that we like to really do studies and prove that things are such. So it also takes time to figure out what is this virus doing on the body? How does this manifest? Why do people with hypertension and diabetes are more susceptible than someone with another kind of disease process? Um, so, so keeping that in mind, I think what has been done, um, the measures taken as far as shutdowns or masks or things like that have been experts' best guess, um, as they're trying to figure this stuff out. Um, I we have these badges we've been circulating around, calling it Operation Enduring Cluster, because hospitals really weren't ready. When I came to my hospital, I looked at the emergency preparedness processes for something like this kind of outbreak, and I was quite disappointed. Being my last job as it was, looking at disease outbreak preparedness, um, just the plans and process I didn't feel were adequate, and I couldn't get to the right people to be like, hey. But as far as the healthcare worker side of things, they keep changing the process, changing where these patients go, changing how they're triaging, because this particular virus has a very broad set of symptoms, and they're very non-specific. So it's not like, um, if you're having to go to the bathroom a lot and you're thirsty and, potentially overweight. Oh, like that's usually a very clear sign you might have diabetes.
Right.
And that's the diabetes process. COVID-19 doesn't have a very clear marker as, oh my goodness, you have this. I mean, anybody could have a fever. Smokers could have a cough. People with COPD could have a cough. You could have COVID and have a cough. You could have COVID and not have a cough. Um, so it makes it more difficult to triage people, to have a clear delineation as to what this disease is, and and they're still working on treatments because there's no cure, there's no vaccine. Everything we treat is the symptoms. Um, it's really up to your immune system to fight it, rather than like, oh, we can give you this specific medication. Lots of facilities and academic centers are doing trials for different types of drugs that might be helpful, but nobody, I mean, the hydroxychloroquine is actually quite dangerous to take. I know the president thinks that that's going to be helpful, but good scientific studies have shown that there's more risks and very serious risks, including death, uh, taking that than there is just you know like he's doing. But that's neither here nor there, I guess.
Right, absolutely. So what you have here is like you just have kind of a cocktail of awful of just not having any way to really prevent it, to know exactly that it's happening, when it's happening, to see it, to know that like this is definitely the source that it comes from, and this is how you could like cut it off. So I guess if,
Well,
oh, go ahead.
I mean, the best things to do is what we call universal precautions. So washing your hands really well, and we do know that wearing masks are good. Not just if you're putting on a mask, it's not really just protecting you. It's protecting other people. So other people have to do it. So the more people who are wearing masks in close contact, the likelihood that the transmission goes down. We do know that. We do know that hand washing and good like hygiene is important. Um, but as far as like, oh, this is a very clear, rate of transmission. But we do know that masks are beneficial, so please wear those.
Right, absolutely. And you just said that the environment that you're in, you didn't feel was, as prepared, I guess, as what you would have liked. Is that would you say that that's probably the norm for most places in the U.S. or?
I would. So like like everything, there's a risk analysis and where you're going to spend your money, right? So we
Hmm.
haven't had a pandemic like this since 1918. It's a long time. So if you only have a limited budget on your hospital, you're going to spend things on what you perceive as a more um, viable threat. So, like, our hospital is more focused on civil unrest and mass casualty situations, which is fair, given some of the climate we have and being in the capital of Virginia. Um, that's a possibility. So we're running scenarios and practicing for that sort of thing. Having a respiratory-based um, disease outbreak was not on anyone's like radar as far as this being a high risk. So having the necessary equipment in mass for it, I don't think anybody really was preparing for that sort of thing. It had been done in some simulations back when SARS was big, but as far as most health systems having um, plans for this type of outbreak, I don't think anyone was really focused on it.
And I think that that's a great perspective. Actually, I was not really prepared for that, and I no, and it makes complete sense. And I really enjoy how you just kind of like stepped around that without being like political or anything. Because yeah, it's like, how do you? I remember I was listening to like a podcast one time about Hurricane Katrina and stuff, and people were asking like, why didn't the people of Houston just evacuate immediately, or New Orleans just evacuate immediately? Sorry, to New Orleans to like Houston or whatever. I wasn't listening to a podcast. I was in a taxi, and we asked the taxi driver about it, and she said, "You got to understand, like we hear this like every year and stuff, and this is not necessarily a direct comparison to what you just said, but it's like if you know that you're getting these." Kind of diseases or you have to treat these things every year that that there's a high probability that's going to happen. I mean, how would you predict and know that you're going to get some worldwide pandemic, with like say that had a respiratory aerosolized transmission and everything? And I guess my next question to you for that is there anything I guess that could have been done outside of just saying like we're going to give more funding to like healthcare, unless you think that is the only answer.
Um, I think the national stockpile, and folks who are way more intelligent than I am when it comes to forecasting and stuff like that, I understand that there was not adequate funding and replenishment of the national stockpile to have PPE.
Hmm.
So typically, certain types of diseases or processes warrant a specific type of PPE. So, if someone has this kind of disease, you'll wear a gown, you'll wear gloves, you'll do this, you'll do this. Um, that wasn't available, particularly for the hot spots in adequate mass. Every time I go into a room, for every encounter I have with a patient, I'm supposed to change out my PPE every time.
And can you explain to the listeners who don't know what PPE is?
Oh, yeah, personal protective equipment.
Right.
So, disposable gowns, gloves, goggles, um, shoe covers. Depending on different types of things like that you might need that. So, what unfortunately has been happening is that we've had to reuse our PPE. So before I left the ED, I had worn the same mask, which I'm supposed to on a normal non-pandemic time, change out my mask between every encounter I have with the patient. Here I'm wearing the same mask for all of my patients. Um, and it can be done, but it's not what we would call best practice. So I think we could have had a little more on the back end as far as supply chain, having access to that from the beginning. I know people talked a lot about the ventilators. They've kind of found that if you're going to end up on the ventilator, that's not good. So they're actually trying to keep people off of those. So those are some like lessons learned. I know that was a big hot topic that was in the news.
So it's not good to
Um,
be on a ventilator.
No, it's never a good
Well,
time to
sure,
be on a
sure, sure,
ventilator.
sure. Like I don't, you don't wake up and say, "I'd love to be on a ventilator right now." No, I understand that,
Um,
but
no, but as far as the COVID process, so folks with COVID, they've been um, anecdotally, and what they've been seeing in this study has been Italy and the U.S. is the folks that end up on them have poorer outcomes. And when I say poorer outcomes, that's just a fancy way to say they die,
mhm,
or they don't recover.
the poorest of
Um,
outcomes.
yes. So, um, yeah, I think we could have done a lot more to have supported the frontline folks with better PPE and better, and obviously hindsight, better planning. Um, but
So, I know what the last question I want to ask you about this is, but I kind of want to follow
hmm
like some sort of temporal process here. So we talked about what could have been done, like maybe
hmm
beforehand. Now, how do you feel about the methods of social distancing? Uh, not going out, quarantining. How effective do you think that measure is? Is it the best thing you have to kind of let people go on with their normal lives as much as possible while also not spreading it? Is this if you were the dictator of the world, is this what you would have told people, while also trying to keep into account the health of world economies and everything? So how do you feel about the methodology so far used to kind of, I guess, flatten the curve? And then also maybe you can give your opinion on like flattening the curve and everything.
Sure. So I think social distancing is our best bet to kind of get back to normal. I've been really pleased when I've gone out and seen like they have the little stops of like please stand here, um, and with a lot of the um, businesses have tried to adapt. I think I think it's going to be really helpful as far as finding that balance of getting back to some semblance of normalcy, but also keeping people safe. Um, if I was dictator of the world, I mean, that's kind of how you have to do it, because they'll. I mean, you have a background in epidemiology, so you could probably explain the curve better than I. But when I think of flattening the curve, to me, it was to buy time for the healthcare systems to be able to prepare to accommodate a mass influx of people.
Which is another thing
Um,
I wanted to talk to you about, was like the was maybe you can explain. So is your particular environment, I don't want to give away like where you work or anything. I don't know if they'd be okay with that or whatever, but like based off of like what you've seen, is it overwhelming, the healthcare system where you are? And maybe you can tell our listeners like why it is important that, it's not so much like flattening the curve is like you can't go outside ever because you're going to get it. It's more like we don't want to overwhelm the healthcare system from people who come in and say we have symptoms or they have it, or so maybe you can explain that and why that's important, or your thoughts on it.
sure. So the healthcare system we have is uh, fraught with a myriad of problems and
Plethora of yeah, right, right.
um but uh and really it's a case of limited access, really, of there's only so many beds for so many people. So just because COVID's going on doesn't mean someone's not having a heart attack or not having another situation that needs urgent medical care. So it's not like we just strictly have COVID hospitals. um, say a hospital only has 30 beds in it. Well, you get 60 people coming in. Everyone, ideally, particularly with COVID, needs to be in a negative pressure room, so a very specialized room. You can't have can't have folks out in the hallway coughing and things like that potentially spreading. So you don't have. It's really an issue of space and resources, because you don't have all the medications, you don't have all the PPE, you don't have enough providers, nurses, doctors, respiratory therapists, the whole crew of folks. There's just not enough for every single person in the United States if they needed to come in and have care. It's not there. So flattening the curve is either kind of trying to space out. So it lengthens the I don't know,
The amount, the rate to which
circulation
people are,
time.
right.
But it gives time for, if we can treat you or get you a medication and send you home, or determine that you can, your symptoms aren't severe enough to be seen in a hospital, that buys us time so more and more people can be seen and cared for, because ultimately, you have to get up to either a vaccine, or how much, I don't know, you can maybe say how much of the population needs to have uh, gotten this before we can get herd immunity. And then it becomes something, like all the other diseases we've eradicated, like measles or something like that. Mostly, measles might be a bad example in some corners, but we have a vaccine, and most people don't have to worry about measles because
There isn't enough
people have
people
been vaccinated.
Right, absolutely. And I guess that segues into my next, question to you is, so it's here. It's probably not going to go away for a long time. We don't have a vaccine yet, and I think that a lot of people think that a vaccine is just something you come up with tomorrow, and it's all figured out. I mean, science goes at the speed of good science, and and so which is good. I know that a lot of people might be saying, like, why don't we just get it out there? I mean, you need to know that what you're doing is effective and it's not harmful and everything. So it's probably a ways out. And I guess maybe closing this out, it's like, what do you think the future is with like a world with COVID? Where do you see this going? Do you think that we get to a vaccine? Do you think we get to herd immunity? Is there anything that you think that public health systems should do to make sure something like this doesn't happen again? Like, how do you foresee what things will look like, and what the future is going to hold, and what should happen going forward?
If I actually knew the answers to all that, I would be.
I don't expect you to know all the answers.
Super wealthy.
Yeah, right. We're not gonna figure it out on this podcast.
Yeah. No, I honestly, no. I don't think we'll get there today. I think well, from what I've read with experts, we will probably see a second wave of this.
Which by the way, I was I'm a big history buff. I was looking at some between two wars things on the Time Ghost channel. I'm kind of throwing that out there. A friend recommended it to me. It's pretty awesome. And the second wave of the Spanish flu is actually the deadliest.
Correct. And that's what they're kind of projecting based on the 1918 Spanish influenza outbreak, but just based on like, I have friends who could probably explain this better, but viruses tend to not be as they are still circulating, but not as active in the summer months. And just like a flu season, it kind of picks up in the fall and winter, and some of that's just by virtue of we're indoors more in those times. Mm-hmm. And not, in the summer we're a little more spread out doing outdoor activities because the weather is better. But also, I think some of it's just cyclical. So I would guesstimate that in the fall we'd probably see a resurgence that may or may not be, depending on how the virus mutates, worse.
Hopefully not.
But I wouldn't be surprised. I mean, when I first saw this crop up on the BBC News in December, and I saw an article about a new virus, I messaged a friend and I was like, "This is going to be a big deal." I didn't anticipate it being this big of a deal.
Why'd you think
that? But just by virtue of studying zoonotic diseases, and that it was going to be something new that we hadn't seen before. And our bodies just don't have like a limited immune system. We can battle what we know, and we do it very well. But it's harder when it's a new demon to fight. So, I'm not hopeful for a vaccine. I don't, as far as I know, and I could be very wrong, and someone might correct me at some point, but I'm not aware of success rates being very high with coronavirus-related vaccines. We don't have one for SARS. We don't have one for MERS. They're tricky viruses um, to come up with something. I think people are going to do, like, some amazing minds are going to do their best, but it's not going to be something that's quite easy to come up with.
Mm-hmm.
And I think particularly us in the West, we have a short memory. I mean, I was even out today and I saw a whole bunch of folks without masks on, um, running around. And hopefully, people don't forget how important it is to wear masks and have hand hygiene and have social distancing. Um, because if we're so excited to get outside and be around people and be with friends or go out to dinner, we also forget to also be cautious, putting ourselves and our loved ones and friends at risk of contracting this, because it's not going away. We're just trying to open back up to, help people get back on their feet and livelihoods and businesses and things like that. So we're trying to find that balance in between. I know Sweden's been pretty successful with how they've done things, but I think some of the Swedish culture lends itself to being a little more collective minded,
Right.
and thinking about those sorts of things than the individualism we embrace here in the US. So
Right. Yeah, absolutely. It there are definitely a lot of factors that kind of make this it's difficult to say the least. So, hopefully things get better and hopefully things change. Do you think that the healthcare system is going to fundamentally change in any way because of this, like getting funding, having some sort of focus on it more now, or?
I would very much hope so. I think, um, and historically in these types of outbreaks, we look to the CDC and the WHO, for their guidance and recommendations and try to implement those. And I think in the current political climate, um, both of those institutions that have historically been the pillars of excellence as far as how to proceed, um, have been stymied,
Mm-hmm.
and their methods have been questioned, and it makes it difficult to have a unified approach, I guess.
Right.
Um, and it's, I mean, every hospital's different. You have for-profit hospitals, you have non-profit hospitals, you have hospitals with state funding, you have all kinds of things. So when you don't have an institution who can kind of provide best practice examples, and you have a variety of different types of healthcare facilities, it makes it difficult, because we might do things one way at my hospital, but the hospital down the street is doing something different. Is it better? Is it worse? Who could say, because it's not uniform. And so I hopefully, um, there, I mean, there's all kinds of new things coming out of this as far as is PPE is concerned and how they're treating people and things like that. So I think there'll be a period of innovation,
Right.
both in the vaccine and both on the ground as far as treating patients. But um, is that going to be enough? I'm not sure.
Well, hopefully it is. Hopefully it is. I mean, and most of us just have to deal with, coronavirus and stuff right now, but you have to deal with, something else, which is, breast cancer. And, I'm so sorry that, breast cancer has affected your life and touched your life in a way. And, I guess that, cause I have other friends who are actually dealing with that now. I guess I'm kind of at the age where that might start presenting itself, and, people I know and everything. So, maybe you can maybe talk about that and how, I guess maybe you found out, words of advice that you'd have for people going through it. Maybe you'd recommend that, girls of a younger age, get tested or do their exams or something, talk about the importance of that. So I guess maybe we can start this off, but like, how did you find out? And was this something that kind of was like a surprise? Is there something that could have been done to where you could have caught it earlier? Did you catch it early anyway? Like stuff like that. I guess if I ask that question, yeah, so many, I know.
So many questions.
Pick one.
So I would say first and foremost, I don't care how healthy you are, how amazing your lifestyle is, how good you eat, how much you exercise, whatever you're doing or not doing. I was never a fan of going and getting annual checks of any kind because I'm like, I'm young, I don't need this. I work in an ER, my immune system's amazing. Who needs to go spend, $40 on a copay to go sit there and get poked by a doctor? But I decided this year, I was like, I probably, should be a better example and go in.
You just decided that.
Yeah, I did.
Wow.
I did because I don't like telling my patients to do something and I'm not,
You don't want to be a
doing
fraud.
the same thing. No, I don't. So I went in for my annual lady exam. And so typically, I'm 33. Women my age don't really get screened for breast cancer. We're historically not at a high risk for having it. But I had a really fantastic nurse practitioner. And so she's doing my breast exam and she's like, you have a little bit of density changes. I'd like you to go in for an ultrasound. And I was like, okay. And that's pretty common. Plenty of women can have density changes or benign lumps in their breast, and it's not a problem. It's just good to make sure that it's not something cancerous. So it took me a month to get in, but I eventually went in. And in that time, I kind of knew that I already had cancer before I went in for that test.
Why? How did you know that?
So they don't. When I was in nursing school, they don't really talk too much about the cancers, but one thing they'll tell you about breast cancer is that you'll have nipple changes.
Mm-hmm.
And I was starting to have that, and I could feel the density in my breast, and to me it was just like, I know that this is what this is going to be. So I go in and I have my mammogram, and I asked the girl, I was like, hey, so what do you think? And she's like, well, we'll have the doctor come talk to you. And anytime anyone says that, that's never a good sign.
Uh-oh. So how did you feel when you heard that then? Was it like a sinking feeling?
I kind of just laughed because I kind of knew. So I was like, okay. So then I went for the ultrasound, and because I'm in a teaching hospital, so we have residents. And the resident comes in and she's like, hey, so I'm going to do your exam. She's like, I'm going to go get the attending. And the attending is like the big doc. And I'm like, oh dear, here we go. Uh-oh. And I'm texting, texting a friend of mine being like, they brought the attending in.
It sounds like they got the big guy now. Like,
yep. And I'm like, all right, here we go.
No snap,
and
strap in.
The attending's like, hey, I'd like to do a biopsy today. And I was like, do what you got to do. Let's go for it.
So at that point, did you kind of know?
Oh yeah. And I asked the doc, I said, hey, so what's, what's your differentials? Like, what could this possibly be? And the first thing she said, she's like, I'll be honest with you, it looks very suspicious for cancer. And I said, okay. So they called me back in the office a day later and gave me my official diagnosis. So I have what's called invasive ductal carcinoma. Okay. So you have different parts of a breast, and so the ducts that typically bring breast milk down through the nipple for breastfeeding, my cancer cells are in there, and I have what's called I'm triple positive. So my cancer cells react to estrogen, progesterone, and HER2. So that means all the lady hormones feeding my cancer.
Oh wow.
So
oh wow.
Yeah. So it's important to go get checked, and and thankfully I'm at an academic medical center because they had it was a weekend, so the weekend plus 2 days, I had a whole team. So I had a medical oncologist, which is a cancer specialist. I had a surgical oncologist who specializes in breast cancer surgeries. I had a radiation oncologist. I had a social worker. I had a navigator. I had all this whole team of medical people to come, and who've looked at my scans and who looked at my stuff and said, "Hey, this is the plan we have for you."
Is that
And
normal? Is that like a normal set of, I guess, resources that that a woman would have?
well, anyone who has a breast cancer would have all of those doctors. Not all facilities do a team approach. That's why I'm always partial to academic medical centers, because you will get more of that comprehensive team focus versus a smaller hospital or facility that you might meet with a medical oncologist, but then you'll eventually have to find a surgical oncologist. And so you'll have to have different members of your team.
Mm-hmm.
Um, so um, I was quite lucky to have everybody right there. So I could ask all the questions that I had, understand what the plan was, why we were doing this drug and not this drug. Um, and so it was really, really helpful. What I'm so grateful for is that I have medical knowledge,
Right.
because I can't imagine being a woman trying to get a diagnosis and trying to understand what all these who are these people, what does this mean, what is this. I didn't have to go through all that. I already knew the medical side of stuff. I had to deal with the life side of stuff, and that's been the harder part for me, is that um, piece of it.
So explain that. So the life side of stuff. So how has this kind of, I guess, affected your life?
Oh
What has
goodness.
changed? Like what has changed for like majorly?
um s- oof. It's for me, it's been the side effects of my treatment.
Mm-hmm.
So what chemotherapy does is it targets cancer cells. Are fast growing cells.
Right.
That's what they do. They divide really quickly and cluster in an abnormal place in your body. And what chemotherapy does is they target fast growing cells. So many of them aren't very selective as to the very specific type of cell. So it when I have chemo, it's targeting, yes, my cancer cells, but it also targets my nails, my hair, my
Right.
mucous membranes,
Right.
um, and it causes and it kills all of them. So I'll get my chemotherapy, and then for the next 7 days, um, I have I can't I don't know how to describe this level of fatigue. It's not like, oh, I did too many reps at the gym, or if I could just go back to sleep for 2 more hours, I'll feel better. Your whole body, your whole essence is fatigued. So like folding laundry deserves a nap.
Oh,
And
wow.
that's been difficult because I'm a very active person. My dog
Right.
and I go for 10-mile hikes, and I
Right.
go and do stuff all the time. So having to feel weak, um, is been a lesson in being gracious to myself, um, and that this is kind of what we have to go through. So I have 6 rounds of chemo every 3 weeks.
So
Um,
every 3 weeks, you're then out for like another week in terms of like your energy. Is it possible to get out at all, or have any ability to like hang out with somebody for a day or something like
so
that?
so yes, but so when I have that fatigue, it also compromises my immune system.
Yeah.
Um, and so I'm what I call a bubble baby,
Mm-hmm.
in that I have to be super duper careful of who I'm around, keeping my environment clean. Not, I'm doing my cat litter box, or picking up after my dog, not wearing gloves. Um,
Not catching
it
coronavirus.
correct. But I will say though, I was diagnosed on March 6th, which is right around the time all the corona stuff was kicking off. And it has been the best time to be a bubble baby, because everyone else can't go out either, and
Right.
has to wear masks and distance. So, I had that added kind of thing that the rest of society is, being mindful about it. in my office job, people wipe down their desks. They put on a mask if they're going to come talk to me. So it's been a good environment, and I'm really really lucky to have that opportunity. I mean, I haven't missed a day of work. I've had really flexible doctors because I know that for those at least those 5 days, I'm no good to anybody. So I schedule my work before my chemo,
Right.
and then I have 5 days off, and then I work my 3/12 shifts, and then on the back end, and they've been really 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 gracious to me. So it's made that transition um, smoother, I think. But for particularly, let's say, young women, um, it's really important to do those breast exams, whether you're doing it in the shower. And men as well can get breast cancer.
Right.
Um,
It's true. How
uh,
young for women would you say they should like really start kind of
I
examining themselves?
I so it's interesting. My my NP brought up the fact that they're not really screening women my age at 33. She did it because she believes it should be younger. So I think the literature out there is varied, but I think we're starting to see more younger women get breast cancer. So there's never like if you got boobs, go ahead and check them, like feel them. There's no like bad time to start. It's not going to hurt you when you're in the shower. Just kind of lift um, your arm up and also just kind of palpate, kind of make like a little like a pincher
Mm-hmm.
and kind of just press around what you've got. And if you're concerned about it, follow up with your doctor and have them, have a professional check it out. But there's never a bad time to start that at all.
That's actually
Um,
very interesting because I feel like as a male, I was kind of told to check for like the testicular cancer earlier, and it just kind of blows me away that you're saying that they're seeing in their 30s, like not really checking for it, because I feel like, shoot, I'm trying to think like maybe in high school we even talked about it. You know what I mean? And I guess that women aren't. I thought that maybe they were educated a lot earlier, but it seems like this is not something that's really talked about, until they're older or what?
I mean, historically, it has been um, women who've been closer to menopausal age that have been getting breast cancers.
Mm-hmm.
Um,
Right.
and and particularly for me, like when I found out, it was hard to find. There were some, but not as many resources for younger women. Um, and that's it's different. It's different when you're a grandma and you have a support system and you're established versus you're a young professional trying to work and do your thing.
And you don't have like
Um,
20-year-old children or anything like that can
no,
like support
and
you.
yeah, and it's a different game. But I have found some really fantastic mentors that are out there and some really great groups that are available.
What are some groups that you could say if there just so happens to be somebody listening with breast cancer right now, like where,
Yeah.
what you would recommend?
There's Young Cancer, there's Stupid Cancer, there's an organization called Charcheret, um, that all of them have a component. I was really lucky. Charcheret put me with a mentor, which has been helpful. I actually have two mentors, and one's a grandma and one's a girl who got breast cancer around my age, and both of them have been very helpful. When I lost my hair, that was really traumatic for me.
I
Um,
bet. I
that
bet.
that both of them were like, had something to say, and it when I was in nursing school, I went and shadowed at an AA. And one of the guys there, he said, if you take nothing away from this, he's like, if you ever have someone who comes in, um, send them to us. He's like, because we can talk to someone who's also an alcoholic in a more meaningful way than anyone can. And that always kind of stuck with me. And I always thought about that. And so when I had breast cancer, it's awesome hearing encouragement from people in my life, but it's different when it's coming from someone who's been there and
Oh,
and who's
absolutely.
and who knows the walk that has that similar shared experience. um and I really like held on to them. um And so there's tons of resources and tons um, groups out there. They send, chemo kits and mentors and wigs and, all kinds of things about styling wigs and all. I mean, I never had a wig in my life. Now I know all about wigs.
Wow.
Um,
Wow.
so you learn all kinds of things, but I guess it's really important to know that you are absolutely 100% not alone. You might feel like it, and in some ways your journey might be different than someone else, but there is a myriad of support out there um, for folks who either have breast cancer or know someone who has it. Um, it's you don't have to scramble in the dark. There's
Right.
you know
Right.
there's a way.
Absolutely. Well, man, that is some heavy stuff. And, I really appreciate you kind of sharing your experience and then kind of, telling people, what they can do if they find themselves in this kind of situation. I mean, we're kind of getting towards the end of this podcast and stuff. So I just want to say, like, thanks a lot for, just the wealth of knowledge that you've just kind of dropped on this podcast. I feel like a lot of people will walk away from this with at least some perspective on something, some newfound perspective on it and everything. And, I really hope that, this breast cancer is something that you're able to, overcome and that it doesn't, have a super negative or continue to have any negative impacts on your life and everything. And, hashtag Team Julie. So
Thank you. I actually got some good news today. I saw my oncologist, and she can't take my mask that I had, so the chemo is working.
So the chemo's working.
The chemo's working.
Excellent. Fantastic.
All my suffering's not in vain.
Oh, wow. Excellent.
So yeah, if I could say one more thing,
Yeah, sure.
for if anyone does have breast cancer out there, and something that's been very helpful for me is a mantra that I've heard. I think it's some military person who said, "If you're going through hell, keep going."
Right.
So keep that in mind. Just keep powering through. Like, I talked to so many women who have had amazing and successful lives and successful relationships and things like that after breast cancer. So it's gonna suck. It's really, really, really gonna suck, but it life will go on, and it'll be more meaningful on the other end for sure.
Absolutely. Well, thank you so much, Julie, for being on this podcast. It was great to catch up again, checking in and everything, and just keep continuing to be awesome and strong and awesome again.
Always a pleasure, Jtrain.
All right. Well, take care.
You too.
Bye.